It's a privilege to be sharing the stage with the stalwarts of endocrinology. What I'll be discussing is basically, the benefits of early weight loss as far as the journey of type 2 diabetes is concerned. These are my financial disclosures. So we know the basic pathophysiology of diabetes. We know that, as the insulin resistance, goes up, the beta cells, they try to compensate for the insulin resistance, and then over a period of time, they can't compensate, and that basically leads to decompensation and eventual stages from, from the normal glycemia to impaired glucose tolerance and eventually to type 2 diabetes. As far as the association of type 2 diabetes is concerned with obesity, as you can see from this slide, the relative risk, as you can see, of diabetes keeps on increasing as the BMI levels go on increasing. And as you can see, the relative risk of type 2 diabetes with a person who has a BMI of more than 35 kgs per meter square is almost 93 as compared to a person who has a BMI of less than 22. So there is a direct positive correlation between the two, which is very well known. How the obesity basically leads to metabolic and heart disease. So we know that in obesity, it's not just the increase in the number of adipocytes, but those adipocytes become more dysfunctional, and this basically leads to two pathways wherein, as sir discussed, it leads to adiposopathy and also ectopic fat, which is basically the metabolic complication of obesity. And then we have ectopic fat deposition within the liver. We have pancreatic or the islet deposition of the fat deposition within the muscles, which increases the insulin resistance further, and also deposition within the myocardium. As far as the the fat mass disease is concerned, it leads to an increase in the cardiac workload, left ventricular hypertrophy, and eventually fibrosis, ultimately precipitating atrial fibrillation and heart failure. So this adipose tissue is not just in excessive amount, but it basically drives the inflammatory pathways across the body and eventually leads to the complications of diabetes. Now coming to the pre-diabetic stage, so these are landmark studies published in late 90s, early 2000. That is the Finnish DPS study, which showed that lifestyle intervention reduced the risk of progression from pre-diabetes to type 2 diabetes. So over a period of 6 years, there was a 58% reduced risk of progression from pre-diabetes to diabetes. The DPP study, again, wherein metformin was also used, showed that over a period of 4 years, there was a 58% reduction in the progression of pre-diabetes to diabetes, and then at the end of 10 years, there was a 34% reduction in the risk of progression from pre-diabetes to diabetes. Again, DiaObecon study showed a 51% reduction in the progression with lifestyle intervention, and 43% at 20 years. And I think the 30-year follow-up, which was published in 2019, also showed a significant reduction in the patients who had initially undergone intensive lifestyle modification as compared to the conventional therapy. So we know that lifestyle interventions play a big role, especially in the earlier stage of the journey of type 2 diabetes, wherein progression from pre-diabetes to diabetes can be delayed, or in many of the cases stopped with intensive lifestyle modifications. So this was a very sophisticated study, which where energy restriction had its beneficial effects on blood glucose, hepatic glucose production, and liver triglycerides. So this was carried out in 11 subjects with a BMI of 33.6, and patients were restricted to 600 kilocalories per day for 8 weeks. And what they found was that, as expected, there was a reduction in the plasma blood glucose levels at the end of 8 weeks. There was also a reduction in the basal hepatic glucose production at the end of 8 weeks, and the hepatic triglyceride content also reduced gradually from week 0 to the end of the study. What they also found out was that energy restriction not only reduces those parameters, but also improves the beta cell function. So as you can see, that the insulin response was tested via the hyperglycemic cleanse, which we know is the gold standard for assessing the insulin response. And as you can see, the first phase of insulin response, so we know that the first phase of insulin response basically starts before even the food is ingested and lasts till around 5 to 15 minutes after the food is ingested, and it's basically the insulin which is secreted from the preformed granules which are there in the beta cells of the pancreas. And as you can see, there is a significant improvement in the first phase of insulin secretion during this 8 week of dietary intervention. They also did MRI spectroscopy and looked at the pancreatic triacylglycerol, which also showed significant reduction from baseline to week 8. So meaning to say, energy restriction has its effects not only on the the blood glucose levels, but also uh, the indirect markers of inflammation also keep on going down, and it not only reduces the insulin resistance but also improves the beta cell function as early as 8 weeks. These are again landmark trials. We know the direct trial in patients with diabetes showed benefits of weight loss. So in the intervention group, people who were restricted to a calorie diet between 800 to 830 kilocalories per day, half of the participants achieved diabetes remission. So almost 46% in the intervention group achieved a remission as compared to the control group. And the co-primary endpoint, which was a weight loss of more than 15 kgs and diabetes remission defined as an HbA1c of less than 6.5% without any medication, was more than 8 out of 10 people lost more than 15 kgs. They basically achieved remission. So 86% patients who had lost more than 15 kgs, there was a diabetes remission. Also in the intervention group, who were restricted with 800 kilocalories, 3/4, almost 74% had stopped taking their diabetes medication at the end of 1 year. So that was 74% in the intervention group and around 18% in the control group. Another landmark trial, that is the Look Ahead trial. So this trial basically tried to look at the effects of lifestyle intervention and weight loss on the hard endpoints, that is the cardiovascular benefits. In this study, they in the initial period, they could not find a statistically significant difference as far as the macrovascular complications were concerned. However, with the degree of weight loss, diabetes remissions and were seen during the initial part of the study. However, the post-hoc analysis had a completely different story. So what they found out was that, as expected, that weight loss of between of more than 2 to 15% is associated with significant improvement in HbA1c and type 2 diabetes related risk factors at 1 year. So as you can see, the HbA1c levels, the triglyceride levels, the fasting blood glucose levels, and again, as we discussed, the blood pressure and the HDL levels, because irrespective of insulin resistance eventually comes down with energy restrictions, and all the chronic disorders, may it be dyslipidemia, may it be blood pressure, may it be type 2 diabetes, they gradually do improve as the patient loses fat. So incremental increases in the weight loss are associated with greater improvements in HbA1c and greater reduction in type 2 diabetes related risk factors. Now this was the post-hoc analysis of the Look Ahead trial, where they looked at the the cardiovascular the composite CVD as well as the risk for CKD in patients who had achieved remission in the Look Ahead trial. And what they basically found out was that patients who had diabetes remission at 1 visit or 2 or 3 visits or more than 4 visits, as you can see, the hazard ratio for CKD came down sequentially in patients who had more visits where they were in remission. Similarly, the composite CVD were also in a gradually declining pattern in patients who had achieved remissions at more visits. So as you can see, the more the patients were able to maintain their HbA1c of less than 6.5%, without medication, lesser were the chances in the long term of CKD and the composite cardiovascular disorders. Again, this was another study. This is the long-term benefit of weight loss after bariatric surgery. This was done in Swedish population. It was a prospective non-randomized observational study of around 4,000 people, where patients undergoing bariatric surgery were compared with conventional therapy with a mean baseline of BMI of 41. And again, what they found out was that there was an 78% decrease in the incident type 2 diabetes in patients who had undergone surgery, 33% reduction in the CV death, MI and stroke, and 24% decrease in the all-cause death. So whichever way you are able to achieve weight loss, it eventually transmits in the hard endpoints, may it be CV death, stroke, or cardiovascular events. So we have seen the benefits of effective obesity treatment. But studies have also shown that once the patients are in clinical trials, they are under observation, they're being called up regularly, the diet is being assessed again and again, they're able to lose this weight. However, once they go off that regime, there is a tendency of weight gain, and this is not just because they've not been followed up as stringently. It is also because there are certain hormonal changes that occur after weight loss, which basically drives weight regain. And there are studies which help us tell the same. So this is the physiological response that happens to weight losses. This is a very important study that was published in NEGM in 2011. So the patients were given very low calorie diet for 10 weeks. So at the end of 10 weeks, they lost between 7 to 10% of the body weight. However, they were followed up from 10 to 62 weeks, and what they found out was that the hunger and the desire to eat increased once the patients were once the study period of 8 to 10 weeks was completed. And this basically occurs because the hunger hormone, that is ghrelin, and the satiety hormones, amylin, peptide YY, and CCK, they decrease over a period of time once the patient has lost weight. Hence the hunger hormones increase and the satiety hormones decrease. That basically drives the patient to have more, and eventually leads to weight regain. There are also changes in the GIP. However, there were no changes that were seen in the GLP levels, and the insulin levels obviously fall. Again, there are changes with the serum leptin with diabetes. So serum leptin is positively associated with BMI. So the leptin basically decreases the appetite at the central levels, and also it has effects on the energy expenditure, wherein it increases the energy expenditure. So what energy restriction does is that it decreases the leptin production, decreases the satiety hormones, decreases the energy expenditure, which eventually drives energy conservation and increase in hunger. So these are the compensatory mechanism. It's just like a roller coaster, wherein a dip is immediately followed by a rise, and this basically makes it difficult for patients to keep that degree of weight that they've lost persistent. Hence, we have now more and more treatment options which can be helpful. We know that the newer pharmacotherapies, which we'll be discussing subsequently, they reduce the weight by between 14 to 21%, and we already know the bariatric surgery, depending on the type of bariatric surgery, can reduce the can bring the weight down between 16 to 35%. Newer glucose lowering treatments offer weight neutrality or weight loss in addition to glycemic control. We know that the OHA is associated with weight gain, or are sulfonylureas and thiazolidinediones, and insulin obviously is associated with some degree of weight gain, and metformin and DPP-4 are neutral, weight neutral, and the drugs associated with weight loss are GLP-1 GIP receptor agonists and SGLT2 inhibitors. And now, hence, this is the last slide. So tirzepatide, which is the first in a new class of GIP and GLP-1 receptor agonists, has been approved not just in United States and Europe, but also in India now, and it has been included as a separate category in the ADA guideline. It is the first and only approved single molecule GIP plus GLP-1 receptor agonist, and I think we'll be discussing more data regarding this molecule in our subsequent slide. But the key messages from this presentation is that obesity and overweight are key risk factors for type 2 diabetes. Weight loss is an effective treatment for type 2 diabetes, but difficult to sustain because of counter-regulatory hormones, and bariatric surgery and pharmacotherapy based therapy on gut hormones are effective not only for treatment of type 2 diabetes, but also bringing down the weight. So thank you for your patient listening.